were listed in Math Plus protocol, and the drug that we would talk today is the norepinephrine. This is one of the topics that is quite expansive, and it kind of connects all the dots that we have been talking about for the COVID-19 for a long time. Important thing to keep in mind is that the norepinephrine is not a drug to be used in the prophylactic stage or in the mild stage or in moderate stage. In fact, this is a drug that is used when the patient is in a shock state, and that is in the ICU or on the ventilator. So this drug also is not a cure or prevention or treatment for the COVID-19 or the virus itself. Instead, this is a treatment that is used when the patient is in shock, which causes the blood pressure to fall. And then we are trying to maintain the blood pressure so that the organ damage does not occur, and oxygenation and nutritional supply continues, and the waste products are removed. So it is really to maintain the blood pressure and blood flow. That is what this drug is used for. So of course it is in the ICU and on the ventilator. So let's start our discussion. And hopefully everybody is keeping safe and happy and healthy. Wanted to show you this. So this is DrBeen on BitChute. And something that is interesting is that even BitChute has not approved so far the Math Plus update video that I had done a few days ago. So a few days ago, we did this video, and it is okay on YouTube, but BitChute somehow did not allow it. But good news is that we have a bunch of videos that are already here, and I'll continue to put more videos here. So with this, let's start. I'm just very quickly going to show you various links that I have. They are present in the description as well. This is a link to what is shock. So shock is a state of insufficient blood flow to the tissue of the body as a result of problem with the circulatory system. And the things that can cause that can be low blood volume or heart issues or problem with the heart filling, for example, cardiac tamponade, or distributive shock, which is called the septic shock, which is the situation most probably with the COVID-19, where the blood vessels have become damaged and dilated and the blood pressure has gone down. Then there is this link here, norepinephrine. That is the drug that we will talk about today. So here is that link. Then this is an important one. This is a study that I've linked here, which shows various interleukins or various cytokines that are playing a role in the cytokine, in the storm, the cytokine storm. This is another study for inflammatory cytokines in vascular dysfunction and vascular diseases. So again, we are focusing on the blood vessels when the patient is in ICU or ventilator. That is why these studies. Then I have a couple of more things over here. This is a management of the critically ill adults with COVID-19. This is in JAMA Clinical Network. And here, if you would see, they have they've talked about use norepinephrine as a first-line vasoactive drug, and it has a weak recommendation and it has a low quality of evidence, but still, this is the first-line drug to help with the shock. Use of either vasopressin in epinephrine as a first line if norepinephrine is not available, weak recommendation LQE. Dopamine is not recommended. And we'll talk about those things in a second. I just want to kind of build a context here. Adding a vasopressin as a second-line agent is suggested if the target 60 to 65 millimeter of mercury mean arterial pressure cannot be achieved with norepinephrine alone. So what they're saying is that if you're giving norepinephrine and the mean arterial pressure is not maintained to the goal that we want, then you can add one more drug to it. This is the sympathetic nervous system. We will talk briefly about that today. And then these are the chromaffin cells that are in the suprarenal medulla, and we'll talk briefly about them as well. Then this is the adrenergic receptors. These are the receptors on which norepinephrine works. So we would look at those a little bit as well. This is interleukin 6, we've talked about interleukin 6 many times, and this is an important player in the shock and then when we are trying to recover from it or treat that. This is interleukin 17. So all of those links are present. let's start our discussion. So here we are, norepinephrine. So norepinephrine is actually one of the catecholamines or catecholamines. There are three types. There is norepinephrine, there is epinephrine, and there is dopamine. These all three are called catecholamines. They are all produced inside our body, so these are called endogenous. And majority of them, they are produced in the nervous system, and they're also produced in the adrenal medulla. And adrenal medulla, we'll look at that in a second. In the adrenal medulla or suprarenal gland, 20% of the secretion is normally norepinephrine, and 80% of the secretion is epinephrine. So if you look here, this is the kidney, and above the kidney is the suprarenal gland. We talked about that yesterday with the corticosteroids. Today we are talking about the middle part of the suprarenal gland, that is this blue one over here. That is the medulla of the suprarenal gland. Medulla of the gland is actually a modified nervous system tissue. It is a ganglion instead of a endocrine gland. So this ganglion acts as a hormone producing or neurotransmitter producing gland over here. So the cells that are present in it are called chromaffin cells, and we'll talk about that in a second. Look here, this is the norepinephrine. Norepinephrine is a principal transmitter of sympathetic postganglionic fibers, and we'll talk about that in a second as well. I'm just giving the whole context here. Then the drugs that affect these amines are used for hypertension, mental disorders, and many more things. So now before we look at these drugs, first thing to keep in mind, once again, norepinephrine is a drug that is used. If you see here, this is Math Plus protocol. This is their full Monty section, that every drug that they are recommending. In that, early norepinephrine for hypertension. It should, however, so check this out. It should, however, be appreciated that despite the cytokine storm, vasodilatory shock is distinctly uncommon in uncomplicated COVID-19, which is that it is not complicated with additional bacterial sepsis. This is why if I go up in their sections for various treatments, this is their cytokine storm treatment. And if you see here, inside this treatment section, they do not have norepinephrine. So it is not that they are actually adding norepinephrine for every ICU or ventilated patient. They are saying that norepinephrine can be used when there is a vascular component. And then they are saying it is not necessary that vascular component will be present in all cases. So this is one reference I wanted to give for Math Plus. The second thing is this, if you see here, this is a document by Society of Clinical Care Medicine, Critical Care Medicine, and European Society of Intensive Care Medicine. So this is them. And I called it critical care, clinical care. This is critical care. In here, if you go through their recommendations for the sepsis management, some of the recommendations here have, so if you look here, vasoactive agents. Vasoactive agents are those agents that would help move the blood vessels. So what we need in the shock is we need the blood vessels to become contracted. So this is why they're called vasoactive. They make the blood vessels move. So for adults with COVID-19 and shock, we suggest using norepinephrine as the first line vasoactive agent over other. And similarly here, this is another recommendation. If norepinephrine is not available, we suggest using either vasopressin or epinephrine as a first-line vasoactive agent over other vasoactive agents for adults COVID-19 patients with shock. And then for adults with COVID-19 and shock, we recommend against using dopamine if norepinephrine is available. So I wanted to make sure that we have some of these as well. T helper 1 and T helper 2, I sometimes write them incorrectly. I write T helper 1 above and T helper 2 below. And the reason for that is that I usually, when I'm drawing, I draw from left side and then I go up and then down here. And in that sequence, I tend to put T helper 1 over here, which is wrong. So I did that in a video a few days ago. And in one of the videos, I put T helper 1 in both places, which was also wrong. So this is the proper structure here. Today, I made sure that I double checked it. So here, what are these things, all of those numbers here? These are all the cytokines or interleukins that are released by the cells that are taking part in the immune system. So if you see here, this is the innate arm, and this is the adaptive arm. Of course, we remove this guy, natural killer cell, but the remaining cells here, these are adaptive arm. So in the innate arm, this guy is the macrophage. And if you see here, macrophage can release interleukin 6, interleukin 1, interleukin 6, interleukin 8, tumor necrosis factor alpha, interleukin 12, tumor growth factor beta, interleukin 18, then granulocyte, monocyte, colony stimulating factor. Here, all those that are written in blue are pro-inflammatory. What does that mean? That these cytokines, when they are released from these cells, they are going to cause more immune cells to come over. They are going to cause chemotaxis. They are going to cause activation of the macrophages. They are going to activate the acquired arm. So they are going to increase the fight in the area of infection. So all blue are pro-inflammatory. And why are they important today? Because it is the blue cytokines that in turn, or that eventually lead to so much inflammation that the whole body and the vascular system starts getting damaged, and we get the shock or septic shock. The ones that are in green, these interleukins are anti-inflammatory. So they try to dampen the inflammation, they try to control the inflammation. Our body has both the mechanisms, pro-inflammation and anti-inflammation, and normally in majority of the people, these two mechanisms work together in a balance. But if that goes out of the balance, that is when a patient goes from the moderate state to ICU, becoming severe and critical. And remember, we have been talking about it, that supplements like vitamin D and C and quercetin and zinc, and then CoQ10 and N-acetylcysteine and glutathione and other antioxidants are really important to keep our immune system in balance. So we have to do our work before and then hope that we do not end up in this state, hope nobody ends up in this state. So back here, we know that once the virus enters our body, so focus here for a second. This is the macrophage. Macrophage takes up a coronavirus. It presents that to the naive T cell. Naive T cell connects with it. Then there are hugs and kisses, which are the co-stimulations. And the end result of all of that is that naive T cell, in the presence of interleukin 12, will become T helper 2. But in case of COVID-19, most of the time, naive T cell would be in the presence of interleukin 4, and it will become T helper 2. Once it becomes T helper 2, it will then release interleukin 4 and 5, which will cause the B cell activation, which will become plasma cell. These B cells would then activate, or not activate, release lots of antibodies. And these are the antibodies which will go and then start neutralizing the virus. In this process, if you see here, there is interleukin tumor necrosis factor alpha released, GM-CSF released, which are pro-inflammatory. Interleukin 10 is released, which we talked about in the past, which is anti-inflammatory. Remember, interleukin 10 suppresses interleukin 2, and interleukin 10 suppresses the macrophage from activation. So it kind of tries to reduce inflammation. So we want our immune system to go in this direction because it is sort of less inflammatory path. If naive T cell, this cell, has interleukin 23 and interleukin 6 available, which, remember, interleukin 6 is over here by macrophage. If that interleukin 6 is present, then T helper 17 cells also become active, or naive T cells become T helper 17 cells, and T helper 17 cells in turn will activate neutrophils, and T helper 17 cells would release IL-17, which is pro-inflammatory, very dangerously inflammatory. If there is interleukin 12 available, then a naive T cell can become T helper 1 cell. T helper 1 cell in turn will become or activate cytotoxic T cells by releasing interleukin 2, and the cytotoxic T cell would cause cellular damage. Here is another character I've made here. I love this character. This character is the natural killer cells. Natural killer cells are not part of the adaptive arm. They are usually part of the innate arm, and they are also cytotoxic. They also look at the cells that are infected and kind of kill them. And if you look here, this interleukin 18 here, which is released by T helper 1, and then there is interleukin 18 here, which is also released by macrophage. These guys will activate natural killer cell, which cause cell destruction. So they would cause the activation of those cells that cause damage. So keep in mind that this damage, today we are more concerned because we're looking at norepinephrine. We're more concerned with the endothelial cell damage and epithelial cell damage and the lung damage. So if you see here, natural killer cell in turn, when it will become active, it's going to release interferon gamma and tumor necrosis factor alpha, which also are damaging and pro-inflammatory. Then, so there's a question here. Questions is by James. Do you believe certain people are predisposed to being dominant in either the Th1 or Th2 pathway, in a sense having an out of balance immune reactions? Yes. And the reason I will give is this. There are some people who respond negatively to some more infections as well, and that causes them to have incorrect outcome. An example will be, look at allergens. Some people have allergies. The definition of allergens are that these are antigens to which 80% of the people do not respond. And then in 20% of the people, their immune system is just upset about them and start responding to them overwhelmingly, and they get allergies and sometimes even anaphylactic reaction and die. So there are changes, there are differences in people's immune system's behavior. And most of the time, for example, in people with COVID-19 who are surviving better, what happens is predominantly T helper 2 pathway becomes active and maybe very mildly T helper 1. But if, on the other hand, in some people, because of their genetic makeup, because of their immune system's behavior, if the T helper 1 pathway becomes abnormally active, then T helper 2 pathway is less active, and that causes the issue. This is why sometimes I actually think that to screen people, and now I'm just giving a hypothesis, it may be total bullshit. To screen people, we may be able to take their immune system cells, put them in a dish, expose them to coronavirus, and then see which pathway is becoming more active, T helper 1 or T helper 2. And based on that, we may be able to speculate that this person, if exposed to the virus, will respond negatively or not. I don't know if it is something that is easy to do and can become a test or not, but this is, I think, an interesting test to screen out the people who may be predisposed genetically to respond incorrectly. So James, very good question. So back here, look at this pathway for a second. In here, when the T helper 1 becomes active, then it releases IL-18, which makes this guy active. It also releases interferon gamma, which makes more macrophages active. So this is also pro-inflammation. So then this is a dendritic cell. It kind of looks functions the similar way as in a macrophage. So I didn't want to write all the interleukins here or cytokines here. If you see here at the bottom of the diagram, there are two more cells I've made. One is the endothelial cell of the blood vessel, and that releases interleukin 8. And then epithelial cell of, let's say, our lungs in our case here, which we are discussing, it also causes a release of interleukin 8. All of these pro-inflammatory cytokines will cause aggregation or chemotaxis of more immune system cells to come over, plus the release of more cytokines. These things would cause local damage, and if they are secreted in a very large amount, then they would start causing endothelial damage. Once the endothelial damage starts occurring, then thrombosis would occur. That would start, plus the blood vessel damage itself would cause blood pressure to start falling. So let's look at that for a second. So look, this is what happens. In a very simple way, all of those cytokines that were pro-inflammatory, they are standing here and they have a rake in their hand, and what they're doing is they are damaging the blood vessel wall. And it's like that you take a rake and you just go over the blood vessels and just injure them. The result of that is there are two things that would happen. Number one, the blood vessel will become dilated. So when the blood vessel becomes dilated, blood pressure falls. So because of the dilatation. Second thing is that because blood vessel is dilated, the cells that are making up the wall of the blood vessel, they are now separated from each other, and that opens up pores between them, which causes the fluids to start oozing out of the blood vessel. Thirdly, when the blood vessel itself is damaged, that would actually break parts of the blood vessel through which those broken parts of the blood vessel, the fluids would also escape. The result is that the fluid that we want to stay inside the blood vessel is now gotten out, which would now reduce the blood pressure as well, plus blood volume as well. So the shock that is happening here, the low blood pressure that is happening here, is because of 2 or 3 mechanisms. One mechanism is that the blood vessel is dilated abnormally because of the cytokine storm. Second is that because of dilatation and because of the injury, the fluids from the blood vessel or the blood compartment is now oozing out or squeezing out easily and accumulating in the tissues. Resultingly, as a result, there would be less blood volume inside the vascular compartment. That puts a pressure on the heart to say, hey guy, the body starts saying, well, I'm not getting enough oxygen, I'm not getting enough nutrition, I am developing a lot of lactic acid. Why do we develop a lot of lactic acid? So imagine these are the cells where nutrition was coming, oxygen was coming, and now that there is blood pressure that has fallen, blood volume that has fallen, there is not enough nutrition and oxygen coming in. So these cells that were functioning with aerobic respiration are now switching to anaerobic respiration, which would then cause them to produce lactic acid. This lactic acid is not only toxic to the local tissue, this would then enter the blood vascular system as well and cause acidosis. So there are so many things that come together to finally cause an issue with the blood pressure and blood volume and lack of oxygenation and lack of nutrition supply to the tissues, which then in turn will cause the tissues to start breaking down and getting damaged. And what do you think, which tissues would start getting damaged first? That is the so I have a comment, I'll look into that for a second. But what happens is that because the sorry, I read that comment here. Because the blood pressure is down and the oxygen is down and the tissues are not getting enough oxygen and nutrition, plus they're developing acid in their local areas, then the tissues start getting damaged, and the tissues that are working more will get damaged more easily and faster and early, and that is heart tissue, kidney tissue, and then of course the lung is already getting damaged, and finally the brain tissue can become damaged as well. So just a very quick break here. So there is a comment from JTJ Music. Sorry, but there is a BitChute problem. They have excluded Dr. Bean's videos from their search engine. It's called a shadow banning. So BitChute is not a solution to the YouTube problem. Interesting. So even BitChute. So guys, if you don't mind, I'm going to put the videos on drbeen.com. The point of putting the videos is not to ask you to pay me. I'm going to make these videos free, but put them over there. I would request you to kind of share those links. By Monday, we will have them up on drbeen.com. We cannot put them up with that much of a speed, so we are a little behind there, but we will have them there, and at least then nobody can stop us from sharing these. I'm actually very, very sad that, look, vitamin D study. Vitamin D is such an important thing, and majority of the people are vitamin D deficient, especially the people with the skin pigmentation and the people who are in the nursing homes and the people who are in homes because of the lockdown and the people who are in the cold area where they're covered most of the time, they have vitamin D deficiency, and vitamin D needs to be there in the correct amounts to save us. What is so bad about having the vitamin D? And YouTube took that video down, and I've been begging them. Now on Twitter, I actually wrote, this is the first time in my life that I wrote to someone that, hey, I'm begging you to let this video go, and they are not activating it. So please don't feel that I'm trying to earn money from it, but it is important for these videos to be there. All right. So now I hope that we have a general overview of the problem that we are trying to solve. The problem is blood pressure has fallen, and there is a need to bring the blood pressure back up. So now let's look at a quick, so we are back towards the epinephrine now. So look at this overview of the sympathetic outflow. So first of all, for norepinephrine, what we need to understand is that it is a catecholamine that is released from our sympathetic nervous system activity. So what is the sympathetic nervous system activity that is necessary here? Today we are going to talk about so many things, and every one of them is a month-long lecture, but I'm going to touch on important parts that are relevant to us today. So look, this is our spinal cord. In the spinal cord, if I draw that once more over here, the structure of the spinal cord is that it has gray matter in it, which is the nervous tissue or the neuronal cell bodies. And then it has white matter in it, which are the tracks, the fibers that are bringing the nerve impulses down or bringing them back up to the brain. So this is what I have made here. So if you see here, in this area, do you see this little thing? We call it a lateral column, this little projection. So thoracolumbar area, that is the vertebrae of thoracic or the spinal cord in the thoracic region, our chest region, and the lumbar region, the lower back part. The spinal cord over there has this extra gray matter in it, which gives rise to the neurons that make up our sympathetic system. Sympathetic system is sympathetic to us, and it is an automatic system. That is, we don't control it. That is why we call it autonomic. So what happens is, imagine if you are chased by a tiger. If I am chased by a tiger, somebody is chased by a tiger. So now their flight and fight instinct is going to be active, and all those things that happen, for example, their eyesight will be set to look far, their heart rate would become fast, their blood pressure will go up, their muscle tone would increase so they can run fast, and so on. All of those things that happen to protect us automatically, these are part of autonomic nervous system, and that system that is doing it is called sympathetic system. So here, these lateral parts, the neurons here in the spinal cord, are called the lateral horn, and they are making the neurons of the sympathetic system. From here, when a nerve fiber comes out, it goes to, with the spinal nerve, this is the spinal nerve here, the nerve fiber comes down through the anterior root, and then what happens is it goes to a ganglion. A ganglion is nothing but a collection of nerve fibers outside of the central nervous system. So it goes here in the ganglion, the fiber normally finishes here. So this sign here, the crow's foot, is to say that this fiber finishes. And this rounded sign here means a new fiber starts or new neuron starts. So from there, the new neuron starts, and then they go to blood vessels, sweat glands, hair follicles, organs in the chest. Similarly, if you see here, they go to all of our organs in the abdomen. And then if you see here, this is what is important for us, adrenal medulla. So what happens is, from the spinal cord, sympathetic fibers come out, they go all the way to adrenal medulla. And here what is important is that when they reach in the adrenal medulla, we say presynaptic fibers. So this fiber relay is called a synapse, where one fiber finishes, one neuron finishes, and a new neuron starts, and these two neurons synapse on each other or end on each other. So the presynaptic fiber ends up all the way into the suprarenal gland, and the postsynaptic neuron is actually modified. It doesn't have any branches of its own. It doesn't have an axon. Instead, it is just a cell, but this is a neuronal cell And when it is excited over here, then it would release adrenaline and noradrenaline. So I hope that is clear. It can release dopamine as well. So this is the anatomy of the system that is releasing epinephrine. Oh, sorry, norepinephrine. Now let's go to the norepinephrine. So again, going back to that anatomy, it is releasing epinephrine as well and norepinephrine, but we are more concerned with norepinephrine at this time. Now, how is the norepinephrine synthesized? Or catecholamines, how are they synthesized? So what happens is we take tyrosine, we convert that into dopa, then we convert that to dopamine, which is one neurotransmitter. Dopamine is further converted to norepinephrine, which we are talking about, that is another neurotransmitter. And then norepinephrine can be converted to epinephrine, which is one more neurotransmitter. So these guys, this guy, and this guy are all neurotransmitters. So now let's look at how it is released, the norepinephrine. So this is a neuron. He looks a little shocked, maybe because he is in the topic of shock. So this is a neuron, and this is the end of the axon. I have dilated that end a little bit to look at what's happening in here. So if you see here, in this end, the tyrosine is brought in to the neuronal end. That tyrosine is converted to dopa. That dopa is converted to dopamine. Then the dopamine is pumped into a vesicle, a storage vesicle inside this bigger neuronal end. Inside there, dopamine is converted to norepinephrine. This norepinephrine will be released out when there is a nerve stimulus, when there is a need. So this is how norepinephrine will be released. Or it would maybe epinephrine or maybe dopamine. So all three are there. So once the norepinephrine is released, check this out. Where will it work? Norepinephrine, epinephrine, both work on alpha and beta receptors. We call them adrenergic receptors. So I will discuss the receptors in a second, but let's just look at where does it function. Number one, norepinephrine, these boxes are norepinephrine's. They would, number one, work on the tissue or the receptor in the second cell. This cell may be an endothelial cell. This may be a heart cell. This may be a smooth muscle of the GIT. This may be a smooth muscle of the bronchial system and kidney and liver and so on. So this cell here can be from anywhere, but norepinephrine would work on alpha and beta receptors on these cells. If you see here, there is an alpha-2 receptor present in the presynaptic endpoint, which norepinephrine can work on as well. When it works on its own nerve from where it is being released, it kind of stops that nerve from releasing more norepinephrine. So this is a negative feedback mechanism through which norepinephrine controls how much more norepinephrine can be brought out. Then back here, norepinephrine can also work on beta-2 receptors that are also on the presynaptic membrane. And if they work here, it causes more norepinephrine to be released. So these are just all regulatory mechanisms. Finally, norepinephrine that has been released, it is taken back up. So the neuron that released it, this blue one, it can take that norepinephrine back up as well and then store it in the vesicle from where it came. So norepinephrine can either be manufactured or it can be reuptaken back into the vesicles. And that is how norepinephrine is taken back and removed from the cleft where it is present. Hopefully this much is clear. Now let's continue our discussion. Let's look at the receptors. What is the action of norepinephrine? So let's say here, we'll start from this place. This is the norepinephrine here. Norepinephrine is connected to alpha-1 or alpha receptor. So alpha-1 receptors are connected to a protein, we call them GQ. And let's look at that for a second. These proteins on the cell membrane are serpentine proteins. That means they look like a snake and they have 7 coils like a snake in them. So 1, 2, 3, 4, 5, 6, 7. And the protein looks like this. We call it a serpentine protein because it looks like a snake. Let's see if I can make a snake here. This is a snake. So normally the norepinephrine would come and connect on the outer side of this on the alpha 1 receptor or beta alpha 2 receptors or beta 1 or beta 2. And then inside the cell here, this serpentine protein would then do a second messenger system, or would send a message inside the cell which would cause the action. So there is a comment here from Harry that 7 receptors. It's really not 7 receptors. The protein is connected to one receptor, but the protein is structured in 7 pillars, and it is structured like a snake. So back here, so when I'm talking about GQ, this is that serpentine protein. It is associated with alpha 1 receptor. When the norepinephrine comes here and connects with them, that causes, if you see here, this is inside of the cell. Inside the cell, protein C or phospholipid C, what is this? PLC protein becomes active. PLC protein would in turn cause PIP2 protein to become inositol triphosphate or IP3 protein. This inositol triphosphate protein causes the calcium. So we're talking inside the cell. Imagine this is a blood vessel wall, smooth muscle. It causes the calcium to be released, plus IP3 produces diacylglycerol, which would then cause protein C, protein kinase C, to become activated. Both of these mechanisms cause the contraction. Now the person has a septic shock or a shock. Blood vessel has become dilated. We want the blood vessel to become contracted. So what do? We give norepinephrine. Epinephrine would cause calcium to be released in the cell, plus produce PKC. The end result is that smooth muscle of the blood vessel wall will become contracted and the blood vessel will become constricted, raising the blood pressure. It cannot raise the blood volume, but it can raise the blood pressure, which would cause more squeezing of the blood and allow the more nutrition to go out and the blood fluids to go out. Now, on this side, this is an alpha 2 receptor. Alpha 2 receptor, when norepinephrine comes and connects there, this is again another G protein, another serpentine protein. This is called GI, I for inhibitory. Alpha 2 receptor is connected with it. This is also on the blood vessels. You also saw that alpha 2 receptor up here was also present here. This is also present, alpha 2 over here. So alpha 2 receptor, when that is activated through the GI protein, this is norepinephrine, that would then cause reduction in cyclic AMP inside the cell. When the cyclic AMP is reduced, that causes MLCK, which is another protein, to be reduced or inhibited. When that protein is inhibited, that inhibition of that protein releases the contractile system to work. So you can say that this MLCK protein was kind of stopping this guy from working. So if you stop this guy from working, then that guy cannot stop this guy from working, and this guy becomes happy and starts contracting. Yeah, so phospholipase C. Atush, thank you very much. I became confused for a second. This is phospholipase C. Okay. So back here, the other mechanism through alpha 2 receptor is also contraction, but the pathway inside the cell is different. So that is the second receptor. Then third, here if you see, these are B receptors. And beta receptors are very important for all of us to know. We have beta 1 receptors and beta 2 receptors. And I remember it this way, that we have 1 heart and 2 lungs. So beta 1 receptors are in the heart and beta 2 receptors are in the lungs. They're also present on the blood vessels too, but heart and lungs are more important. Excuse me. So here, norepinephrine has connected with GS protein. This is also a serpentine protein called GS, S for stimulation. Beta receptor is present with them, and norepinephrine comes in and connects. So imagine this is beta 1, and imagine that means this is a heart. So look at norepinephrine's action on the heart. What would happen is it would actually increase the cyclic AMP. So see, with the alpha 2, it is reducing the cyclic AMP. So it is the same exact neurotransmitter or hormone, norepinephrine, but depending upon which receptor it worked on, it would either cause smooth muscle contraction or smooth muscle dilatation or some other action. So it is not the norepinephrine itself, it is a receptor with which it connects. So if it connects with the beta receptor, then it increases the cyclic AMP inside the cell. When that happens, if it is beta 2 receptor, then the smooth muscles would relax. So of course you can imagine we would not want to give beta 2 receptor agonist in the case of a septic shock. Fortunately, for the norepinephrine, the primary action of the norepinephrine is vasoconstriction. That means on alpha 1 and alpha 2. And its smaller action is on beta 2. But still, even if the beta 2 receptor action is present, it is useful because beta 2 receptors are present in the lung bronchi, and they would open up the lungs, they would dilate the bronchi and improve the breathing, which is also very valuable in the patient who has COVID-19. If this is a beta 1 receptor, that means if it is a cell inside a heart, then that causes the heart muscle contraction to improve. And we want that because the patient's heart is not working correctly, patient's blood vessels are dilated, blood pressure is low. So if heart can improve its function, then that would also help improve the blood pressure. So what kind of functions are improved in the heart? The force of contraction is improved. And the force of contraction is called positive inotropic effect. The rate of contraction, that is the number of heartbeats per second or per minute, will improve. That is called a positive chronotropic effect. Chrono from time, like chronological. Chrono is time, so positive chronotropic effect. And then velocity of the conduction within the cardiac tissue also improves, and that is called positive dromotropic effect. What is the end result of all of that? The end result of all of that is that the blood vessels would constrict, heart rate, heart force of contraction, heart's conductivity would improve and increase. The beta 2 effect on the blood, on the lungs, would cause the lungs to open up, bronchi to open up. So all of these are very valuable outcomes that we can get with norepinephrine. So this is the this is the discussion for today. My apologies if BitChute is also not working that well. I have given that link to some people, and they say that when they click on the link, it says does not work. But I'll keep putting it up on BitChute as well. I'll put it up on DrBeen as well. I'm making those videos in DrBeen free. If you bought something from DrBeen, awesome, that supports me. But if you did not, we'll make COVID-19 videos free. So you can go there. So please like, subscribe, and share these videos. And please, when I share the link for DrBeen, please, I would need your help to share it so people can go and watch it over there. Especially the videos like vitamin D. I'm very annoyed. You can see I'm very annoyed that videos like vitamin D are removed. And the YouTube says that these videos are removed because somebody marks them as inappropriate. Then YouTube goes in and does a review and says, yes, they are inappropriate, and removes them. So who are the people who are marking vitamin D as inappropriate? I cannot imagine that. Anyways, sorry, I don't want to. Tomorrow I will be off. So I'll see you guys on Monday. Stay safe, stay happy, stay healthy. I'm also writing up a small document to present to all of you for what are the prophylactic things to do and what are the things with the mild symptoms to do. So thank you, please stay safe, and talk to you later. Bye-bye.